we're going to discuss the cardiovascular system section of electrophysiology of the heart. And here we're just basically trying to understand how blood flows through the heart, what is required physiologically from the heart after looking at the anatomy of the heart and the placement of the heart in the body. So the active recall questions that we want to answer here is how the heart muscles, what the heart muscle requires to function, what an action potential is and how it occurs. And we also want to describe the cardiac conduction system, so how the heart actually pumps blood, which is through the sinoatrial node, the atrioventricular node, the His bundle, and the Purkinje fibers. And then lastly, we want to describe the effects of the autonomic system. We know that the autonomic system is a component of the peripheral nervous system that regulates involuntary physiologic processes such as heartbeat, heart rates, respiration, digestion, or sexual arousal. So let's start off with the first question with what the heart muscle needs in order to function. Right, so the myocardium would need, firstly, I think, oxygen, and then secondly, it would need nutrients. Thirdly, it would need an action potential, which we'll describe shortly what it is. So these are the things that it would require in order to function. We know that the neural signals for the heart to function don't come from the brain. So it's the only organ in which the neural signals don't come from the brain, but it has its own conduction systems. And the way in which it communicates with the brain is through the autonomic nervous system, as we'll describe later. So these systems that are there that exist for the heart itself, the cardiac conduction system, allow the heart to contract autonomously. And so hence why a transplanted heart would still operate if provided with oxygen and nutrients, regardless of input from the brain. So something to note is that cardiac activity is coordinated, and when we talk about the cardiac conduction system, we'll understand why. And to be effective, we need the atria and the ventricles to contract in a coordinated manner, and this activity is coordinated by the heart's conduction system that we will speak about. Also, something to note here electrophysiologically, the heart is connected entirely. It's connected by gap junctions. Right? The electrical connection of the heart is gap junctions that allow the action potentials to move from one cell into another. And also, it's connected by intercalated discs, which support the synchronized contraction of the cardiac tissue. So when questions come up of the electrical connection of the heart, it's two things: gap junction for the action potential to jump from cell to cell, and then intercalated discs for synchronized contraction. So let's move on to the next question, which is the question of what an action potential is and how an action potential occurs. So an action potential is it's a nerve impulse. It allows the movement of ions across the cell membrane. So we know that within a cell, we've got ions, and outside of a cell, we've got ions, which determine the positivity or the negativity of the cell, and then which determines what happens to the cell. And in this case, with the heart muscle cells, we want them to be contracting. Action potential occur in two areas. They occur in the nervous cells, and they also occur in the muscular cells, right? So such as the heart muscle cells. And the aim of the action potential, so in the nervous system, the aim is to deliver a nerve impulse, like a message. And then in the muscular cells, it's to contract. So important to note, so action potential, it has functions in the nervous muscle, and also has function in the nerve muscle, and also has function in the muscular muscle. In the nerve muscle, which we'll learn when we do the CNS, the aim is to convey a message, which is an impulse. In the muscular cells, it's to contract, which is what we're interested in terms of the heart. So all cells have a resting membrane potential. This is when the cell is relatively negatively charged. That's what we call a resting membrane potential. It's when the cell is negatively charged. And you may ask, why does a cell need to be negatively charged when it has positive ions like potassium ions in its intracellular fluid? We say it's, and that's why we use the term relatively more negatively charged, because the sodium, which is more positively charged, is outside of the cell, and then the potassium, in comparison to the sodium, is less positively charged, and that's why we call it relatively more negatively charged, and that's the resting membrane potential. So now the big question: how does an action potential occur? We see here we have a diagram here, and I think what I have is I have the cardiac membrane potential that I'm using for illustration here, and not the nerve one. So cell starts off at resting membrane state. So minus 90 MV is equals to resting membrane states, resting membrane potential state, and then it gets an input. 1 second. So it will get an input or a stimulus, right? It could be sensory, it could be pressure or something, which disturbs the membrane potential because now it's time for the heart to beat. And what happens is that the voltage-gated sodium channels of the cell, they open up after the stimulus. So the stimulus in this case will be the heart needs to pump blood, right? So the cell's voltage gated sodium channels, remember the sodium's outside the cell, they will open up briefly, and then what will happen is that sodium will flow in. So sodium influx occurs via the fast channels. Hence, the membrane becomes temporarily more positively charged, which means it rises from minus 90 MV to minus 55, and that's because of the influx of sodium. So when sodium influxes, we see that the membrane potential is increasing here, and it goes to around minus 55 in this case, right? As the impulse passes, the potassium channels, they open for potassium to flow out, and we call this a potassium efflux, where the potassium flows out, and then and this happens in an attempt to return the cell back into resting membrane potential, because the cell likes to be in resting membrane potential. So as sodium is flowing into the cell, potassium flows out to balance this. And this is in an attempt to return the cell back into resting membrane potential. And this starts at around minus 30 MV, right? It starts at around minus 30 MV. And so when this happens, the sodium also closes and the sodium stops flowing into the cell because of the balance of potassium efflux. The potassium channels, they remain open. And when they remain open for a long time, the cell becomes more and more negative until it reaches a state called hyperpolarization. And hyperpolarization state occurs at around 70, minus 70 MV. That's hyperpolarization. That's when the cell is now going back into resting membrane into a resting membrane potential. And so this is how it occurs. There's also a point where there's calcium influx, right, which balances out the potassium efflux, just to ensure that the contraction of the heart occurs at optimal level. So that's just to remember about the resting membrane state, how it moves from a more negative to less negative into the positivity state, and how the ions balance each other for this to occur. And that is the action potential, which is aimed at the contraction of the heart muscles. So on a cellular ion level, this is what is happening when our heart muscles are contracting. So now let's move on to oh, and something that is important to recap here when we talk about the cardiac action potential is just a recap on how the blood then flows through the heart. So remember from anatomy, we said that there's two entry points, two gates. We have the superior vena cava bringing in blood from the head and the neck, and then we've got the inferior vena cava bringing in deoxygenated blood. So blue is the deoxygenated blood from the rest of the body. What then happens is that this deoxygenated blood will enter the right atrium here. So we see that it's entering it's entering the right atrium, and as it enters the right atrium from the upper to the lower body through these vena cavas, deoxygenated blood then flows from the right atrium to the right ventricle through the tricuspid valve, right? So it's flowing here from the right atrium to the right ventricle through a valve, which is a gate that opens to let deoxygenated blood flow through the tricuspid valve into the right ventricle. So when it is in the right ventricle, when the ventricles fill up, this valve needs to close, the tricuspid valve needs to close, and this deoxygenated blood needs to go and get some oxygen somewhere. And so it will flow through the pulmonary artery and it will go into the lungs, right? Into the lungs. And here the main point is to fetch oxygenated blood. Now we can see that the blood comes back and it's red and it's coming from the lungs. And from the lungs here, it flows through the pulmonary vein, which will carry the oxygenated blood from the lungs into the left atrium. So the blood is now here in the left atrium. It's red, it's oxygenated. And then this oxygenated blood will then flow from the left atrium through this valve, which is the mitral valve. And remember our orientation when you're looking at a patient, this is their left side and this is their right side. So it will then flow through the mitral valve into the left ventricle. This is the oxygenated blood. When the left ventricle fills up, this mitral valve, the door must close, and then this is to prevent backflow back into the left atrium. And when we look at pathologies, we can see where this goes wrong, where these valves don't close, and then we have regurgitations, etc. And then lastly, this oxygenated blood will then leave the heart through the aortic valve into the aorta, and then it goes to the rest of the body to supply the rest of the body with oxygenated blood. So that's something to take into account in terms of what's happening electrophysiologically when blood is flowing through our heart into our lungs to the rest of the body, which happens every second of a person's existence. So that's quite interesting. And so now we move on to the next question, which is the question of the cardiac conduction system, right? So the cardiac conduction system, within the cardiac conduction system, we said this is how the contraction of the heart occurs. There are two types of muscles in the heart that we need to remember. We have the cardiomyocytes, which are the heart muscles. And then we have the cardiac muscles of the conduction system. Then we have the cardiac muscles. Cardiomyocytes are the small muscles. Then we have the cardiac muscles of the conduction system. And the cardiac muscles are, we have the sinoatrial node. We have the atrioventricular node. We have the right and the left bundle branches. With right and left bundle branches. And then lastly, we have the Purkinje fibers, right, illustrated here. So we said we have the sinoatrial node, we have the atrioventricular node with the bundle of His, the left and the right bundle branch, and then we have the left anterior division, which then divides into the posterior division, and lastly we have the Purkinje fibers. So what are the functions of each of these, right? So we've spoken about action potential and what it does in terms of helping the contraction of the heart. Now let's just discuss each one of the cardiac muscles and what their function is in the contraction of heart. So firstly, let's look at the sinoatrial node. So the sinoatrial node is what we term the pacemaker of the heart. So when this is damaged, that's when we need a replacement pacemaker, an artificial pacemaker. So that it normally generates an action potential, which is the electric impulse that initiates contraction. So it's the pacemaker of the heart. It's like the starter engine. When you put the key and the engine goes vroom, that is what the sinoatrial node is. At rest, the sinoatrial node will generate around 90. So the books differ here. So there's 90 to 100 beats per minute. Some books say 60 to 90 beats per minute. However, when it's in its parasympathetic state, this is unregulated, right? Unregulated. But if you're in parasympathetic states, it will generate around 70 beats per minute, right? And that is our heartbeat. That's when they say normal heartbeat, 60 to 100 beats per minute, right? In sympathetic, in the sympathetic states, the sympathetic nervous system, the heart rate can shoot up even up to 150, and this is the sinoatrial node assists in this, right? So where is the location? So in terms of the location, it's in the posterior wall. So it's located in the posterior wall of the right atrium. Always remember orientation left, right when you're looking at a patient. So it's in the posterior wall of the right atrium near the opening of the superior vena cava. That's where it is. The nature of the action potential, we said continually it's depolarizing at 90 to 100 beats per minute. It takes about 50 microseconds for the action potential to reach the atrioventricular node. And what is its role in the conduction network? It sets up the pace for the heart as a whole. That's why we call it the pacemaker, right? And it exits through the right atrium, travels through Bachmann bundle to excite the left atrium. So when this action potential is started, this electric impulse is started here in the sinoatrial node, it needs to travel through the Bachmann bundles to excite the left atrium, right? And the way it travels is through internodal pathways, which we won't get into right now, right? So from here, another thing to note is that the what portion of the myocardium is served by the sinoatrial node. The sinoatrial node will serve the right and the left atrium because it's located in the atrium. So it will serve this portion, the right and the left atrium. Then we move on into the atrioventricular node, which we can call the second pacemaker of the heart. So that's when, if this is not functioning, the heart will then go to its second pacemaker. So whenever there's damage to the sinoatrial node, the atrioventricular node will kick in, right? Although it doesn't generate many beats, it kicks in. It's the second in command. It's slower than a sinoatrial node. It will generate an impulse of about 40 to 60 beats per minute, which is not the greatest, right? In terms of its location, it's located, so we can see the atrioventricular node here. It's located in the inferior portion of the interatrial septum. So we can see the interatrial septum here. It's located in the inferior portion, and it's directly above the tricuspid valve. That's where its location is. In nature of its action potential, we said they're slower. They're 40 to 60 beats per minute. And what is its role? So main function is to delay the inputs by about 0.02 to 0.05 milliseconds. And this is important. Why do we want this delay of the inputs? Because it ensures that the atria have ejected all the blood before it conducts into the ventricles. So the AV node also functions to conduct impulses to the ventricles, but also as a gateway, like a delay tactic, to ensure that there is proper ejection of blood from the atria into the ventricles, right? So it aside from delaying, we said it so main function is delaying that impulse from the sinoatrial node into the bundle branches, right? And in that process, it's allowing the atria to completely empty its contents before the ventricle can actually contract. And it serves, in terms of the portion of the myocardium that it serves, it conducts the SA node impulses to the Purkinje fibers. So it's the midway, like the gateway in between. And after this, from the AV node, the impulse will then travel down to the bundle of his and the Purkinje fibers, right? Let's start with the bundle branches, the bundle of his. These are the third in command, so they're third. Now, normally, so impulse is generated in the sinoatrial node to the atrioventricular node to the bundle of his. It's third in command, so if the first two are failing, that's when we could generate an impulse. And here, bundle of his will generate an impulse of about 20 to 40 beats per minute, which is not great at all, right? Not enough for survival. Its location, we see the bundle of his here. The bundle of his is located at the fork of the branches, right? Superior portion of the interventricular septum. And its role, it serves as the only connection between the two atria and the ventricles. So it's the only connection between the two atria and the ventricles. And remember the atria and the ventricles, as we mentioned in our anatomical section, that it's isolated by the the fibroskeleton, and it's isolated by the fibroskeleton. So in terms of the portion of the heart that's served by the bundle branches, it transmits the impulse from the AV node to the right and the left bundles, and then along the interventricular septum to the apex of the heart. Then the impulse will then travel to the Lustin command, which is the Purkinje fibers, right? The Purkinje fibers, they don't contract during impulse transmission, so they don't contract. They can depolarize, generating an impulse of about 15 beats per minute. And in terms of location, so the Purkinje fibers, they are located in the inner ventricular walls. So the Purkinje fibers are here in the inner ventricular walls, right? Just below the endocardium, and they begin at the apex of the heart, as we can see. Their main function, the main nature of the action potential is mainly to conduct, right? Not necessarily to assist in the contraction. They do carry the contraction impulse from the right to the left branches to the myocardium, to the ventricles, right? And can assist in the contraction, but that is not the main function. So that's that with the functions of the cardiac muscles and how the cardiac conduction system functions. Now we move on to the next question, which is the effects of the autonomic nervous system. So we said although the heart can operate on its own, it communicates with the brain via the autonomic nervous system, right? And we said the autonomic nervous system is part of the peripheral nervous system that regulates involuntary physiological processes where we don't have to volunteer, like walking is a voluntary motor movement, it can be voluntary, but heart rate, blood pressure, respiration, digestion, sexual arousal are involuntary physiological processes, and they are a function of the autonomic nervous system. And then just as a recap, we remember the parasympathetic nervous system. Parasympathetic nervous system innervates the sinoatrial and the AV nodes, and remember to generate that impulse that we spoke about, which is about 90 to about 70 beats per minute, or 40 to 60 beats per minute if we're talking the atrioventricular node. Right. So the stimulation will go as follows. There's a release of acetylcholine after the action potential is triggered. The muscarinic receptors of the sinoatrial and the atrioventricular nodes are then stimulated. This causes increased potassium permeability, so potassium flows out. There's hyperpolarization of the cell, and those are some of the gaps or the fill-ins for the action potential that I was discussing, right? Then we have this is in the parasympathetic nervous system, right? This is to lower heart rates. So parasympathetic nervous system will lower the heart rate, and we said this is what happens, right? There's stimulus, acetylcholine is released. After acetylcholine, muscarinic receptors are activated. When they're activated, potassium efflux occurs. And then there's hyperpolarization of the cell. And the heart rate slows. Now let's see what happens when the heart beats, right, in the sympathetic nervous system. In the sympathetic nervous system, we know that this is fight or flight. It also innervates the sinoatrial and the atrioventricular nodes and the ventricular muscles. And the function here is to increase the heart rate and increases the force of contraction. And what happens in this case? The arteries dilate. So we have firstly the indirect stimulation. Indirect stimulation, so there's stimulation of the sympathetic nerve fibers, right? So noradrenaline or norepinephrine, right? They're stimulated at the cardiac synapses, and what happens, the stimulus then binds to beta-1 receptors. Remember, beta-1 for the heart, beta-2 for the lungs, to the beta-1 receptors. This then initiates kickstarting the cyclic AMP pathway. And when it's initiated, it increases sodium and calcium permeability. So there's an influx of sodium and calcium, and when this happens, we know that then the heart muscle will then contract harder, and the heart rate is increased. So in terms of differentiating the effect of influx of sodium and influx of calcium, so both function to make the membrane drift quicker to threshold, initiating increased heart rate. So these things are important to remember. In the parasympathetic state, which is our rest and digest, what is happening? The heart is beating slower. Why? The stimuli triggers acetylcholine. The muscarinic receptors are triggered. They activate the efflux of potassium. There's hyperpolarization in action potential, and the heart rate slows down. In the sympathetic nervous system, there's indirect stimulation of the noradrenaline and norepinephrine fibers, and then which binds to the beta 1 receptor. So remember, the receptors to muscarinic would be in the parasympathetic, and then beta 1 receptors will be in the sympathetic, which triggers the cyclic AMP pathway, triggering the influx of sodium and calcium, resulting in an increased heart rate. The force of contraction then increases. And remember, for calcium, it's mainly the one that is responsible for the contractile force. So influx of it makes the heart beat harder. And so that's it for the electrophysiology of the heart.